Thanks, everybody. Thanks, Mark. I also have nothing to declare. I'm not a clinician. I'm not even a social scientist. I have no money. I'm a basic scientist, so, and I've spent a whole 25 years studying substance abuse during pregnancy from a basic science perspective. I have a lot of admiration and love for the placenta, so I've managed to work it in a little bit. I always try to work it in there. And as I said, I'm a basic scientist, but I've spent my career in clinical departments, psychiatry, Center for Drug and Alcohol programs, OB/GYN departments, obviously. So I seem to have developed a lot of clinical osmotic information. So what I'm going to do is we're going to have a little healthy science break this afternoon because you all had an intense morning. And we're going to talk about the science at a kind of a high level. I didn't get down into the weeds, but the science related to cannabis exposure during pregnancy, potential impacts on pregnancy outcome, and fetal development. Sounds exciting? Okay. So my first exposure to cannabis was in the 70s. I think my parents took my cousin and I to the drive-in movie in our wooden paneled station wagon. In the back, I remember it was exciting. It was our first one, and we saw Gremlins, and then there was a movie called Up in Smoke, Cheech and Chong afterwards. And so I think we left after about 10 minutes because my parents didn't think maybe it was the best environment, probably because of the language. But every time I think about cannabis and pregnancy and the questions around it, I'm like, is it up in smoke? Where are the answers? And so that's my pun for the day. So this is a slide that I borrowed from Kara Tannenbaum. We spent a lot of time looking for information about the prevalence of cannabis use during pregnancy in Canada, and we couldn't find any. So again, we're reverting to the U.S. data, but it slowly increased over time. And there is a bit of a concern around the use during pregnancy. Our Society of Obstetricians and Gynaecologists of Canada is actually made up of 4,000 perinatal care providers, nurses, midwives, family docs, and OB/GYNs. And we hear a lot from them about their concern about cannabis use during pregnancy with respect to nausea and vomiting, and they seem to see it a lot in their younger patient population. So we do get a lot of questions about that. There was a study that was published recently in the American Journal of OB/GYN that about 70% of pregnant and non-pregnant women believe there's slight or no risk of harm from using marijuana once or twice a week during pregnancy. And this was the only data that I could find around kind of public perception related to use during pregnancy. So what's the deal? There's messaging, it's natural, it's organic, it's vegan. I made that up myself. I think it is vegan. And it does help with nausea and vomiting during pregnancy. And there's been a lot of messaging on the internet. I spent a little bit of time Googling in terms of some of the more popular pregnancy websites that the public get their information from. And so you can see, I put a few examples in. There's blogs that are out there. And so we do know that women are getting information and messaging. We do know that perinatal care providers want to know information. They want to know the science. They want to be able to tell their patients the evidence behind what they're recommending in terms of practice. So what's unique about the prenatal period? I'm sure many of 52% of you are physicians. I'm sure you studied some piece of this in medical school, but we do know that the preconception all the way through pregnancy and the early child development environment really shapes future health. And this is important, this was actually my field of expertise, is more alcohol during pregnancy, but I did a little bit of nicotine, a little bit of cannabis, and quite a bit of cocaine in mice, studying the effects on pregnancy. Just put that out there. See if you're awake. In 1973, there was really it really changed the field when Jones and Smith realized that alcohol use during pregnancy did have neuroteratogenic impacts on fetal growth and development. You couldn't always see it. Most of the people sort of look normal, but their neurodevelopment was really severely impacted. And sometimes those subtle differences and that become big only show up when they're neurocognitively challenged, kind of around the school age. So this really changed the field in terms of teratology, and knowing that exposure to agents that might be harmless to mom may actually have significant impacts on the fetus, and also that they may only show up later in life. We do know that the central nervous system and all aspects of it are susceptible to exposures throughout fetal growth and development, the entire gestation, and we do know that's very strongly illustrated from the alcohol field. And we do also know that there may not be structural effects. The brain might not look differently, but it really does function differently. Whew, take a breath. Okay, so the other thing that really switched around and started people thinking on a different level was Barker. Anybody know David Barker? Anybody been in an elevator with him? Because I have. It's quite exciting. So he really started to explore the associations between prenatal environmental events and birth outcome and postnatal development. Again, he studied the placenta, relationships to birth weight, was able to predict later life cardiovascular disease, which is fascinating. But this whole field became fetal programming. And DOHAD researchers, anybody know what DOHAD is? Developmental Origins of Health and Disease. So this whole field has really broadened their interest towards mental health. So what can happen prenatally, even preconceptionally, that may impact mental health risk in the future? And it's a really amazing and fascinating turn that the field has taken. And so then the question is, what's the increasing use of cannabinoids? And how has that raised questions about effects on pregnancy in the developing fetus? So what's the deal? So we do know, and you've heard this morning about the prevalence of cannabis use. In the Western countries, it ranges between 3 and 25% in pregnant women, often used with tobacco. And we do know, we have a Canadian database actually of about 700 individuals who have been diagnosed with fetal alcohol spectrum disorder, and 30% of them were also exposed to cannabis. And so that gives us some ideas about the complexity and the relationships with other substances. And we have to keep that in mind when we're thinking about pregnancy and studying pregnancy. So there are some potential, and I do say potential and keep that in mind, deleterious effects for fertility and pregnancy outcome. We do know that THC can cross the placenta, our new favorite organ. It can accumulate in fetal tissue and maternal milk. So what? Who cares? You learned this morning in Cannabis 101 about the receptors. And so we do know that the CB1 receptor has been found in the uterus, and it could play a critical role in the onset of labor. We do know that cell migration ability was decreased in preterm labor-derived cells that had been exposed to THC. So there may, again, be another scientific mechanism that underlies possibly an increased risk for preterm birth associated with cannabis exposure during pregnancy. We also, of course, find the receptors in the placenta, and there are some studies that show that in human tissues that amnion development, which is an essential part of the placenta, may be affected, and that also increased placental resistance, which means that there's probably changes in blood flow, which has a whole other cascade of events, and we do see that with alcohol, and we also see that with cocaine exposure. And then there's mouse models found that there's significantly less maternal weight gain, smaller babies, shortened gestation, and that's all a little bit of preclinical data from the mouse models. So what else? Here's just a list, a very high-level list of what is actually in the literature, what has been shown in one study or another, either in the preclinical models or in the human models. And here's a whole list of things that have been shown in some studies. I won't go through them all because you can see them. So we know that there are some potential effects on pregnancy, both from the human and the animal models. But what about the fetus? So pregnancy is one thing. We saw that there could be increased risk. Mostly the data say for intrauterine growth restrictions, small babies, short gestation, preterm birth, and odd placentas. So how might we actually affect the fetus? So there's some studies that show that the aorta diameter is smaller. There's been the receptors again, shown and mapped in the early brain throughout fetal development. And we know also, and I think we heard this morning as well, that the endogenous system has a central signaling role in brain development and could account for some of the executive functioning deficits that are seen as these children grow into their teen years. And there have been 3 human nice longitudinal studies that have shown different things because of the different methods, but they all do show that there's a potential impact for some of the neurodevelopmental issues, and executive functioning is a big one. Incidentally, it's also big with prenatal alcohol exposure. So we also know that the brain goes through critical periods of fetal development, and so depending on what piece is developing at that time, and if there's an exposure during that time, then you could have an effect that's specific to that structural development. That makes sense. And then depending on when it's exposed, you could have different neurodevelopmental impacts that happen on the brain. And however, all of that to say is you really have to pick through the literature, but the data on whether the exposure alters the structure or molecular human fetal brain are scarce, and you can imagine the difficulty that there is with really studying the human fetal brain. So, what have we shown here? And again, I'm just summarizing it. Oh, I think this is the same slide that I had before. Oh, I'm going backwards. Oh, so I did show you some brains, because there's never any good science talk without a good brain picture. And so this is actually some human brains, and they're basically showing you that there's altered thickness in the front part of the brain. And so I'm really bad at directions. And my neurodevelopmental pediatrician friends tell me it's because I have a prefrontal cortex issue, probably because my mom went out on New Year's Eve during pregnancy and had beer and wine, but don't tell her I said that. And so there are differences in function that happen because of that prefrontal cortex. And so cannabis actually increases, prenatal cannabis exposure in some studies, increases that thickness, which you think might be great because you have more brain. But it's not really great because it affects the pruning and the way that the brain matures and kind of is selective in terms of its function. And so it could also have some neurodevelopmental impact from that. So, as I suggested, there's 3 longitudinal studies that I could find in the literature that looked at humans, fetuses exposed, and then throughout up to adolescence, one study did. And they did show that there were short and long-term effects, or increased risk of short and long-term effects, like aberrant behavior in newborns. Basically, they were restless and they didn't sleep well and they were irritable. I do not want a newborn like that. Cognitive deficits, inhibitory control, some of these kind of outcomes. The pruning that I mentioned, the pruning is because of the thicker cortex. Then people started to think, okay, let's get this framework going. So we were talking about a double hit potential. So I just talked to you about DOHAD, and you guys all remember that it's developmental origins of health and disease, and some of the cardiovascular implications because of the endogenous cannabinoid system and its roles in cardiovascular development and function. But then we can have a second hit postnatally. So is there increased susceptibility to environmental stressors, nutrition, social determinants, et cetera? And this brings in the whole field of epigenetics. So if you have a fetus who is exposed to something during pregnancy, then does that make them more susceptible to other exposures later in life that could cause increased risk for health effects? Does that make sense? I'm going to show you a really easy graph, a really easy figure, so you'll figure it all out. See? Not even that hard. And here, this is a complex figure, but it does show the complexity because we know epigenetics is complex. We know social determinants of health now have an epigenetic impact. They can change a mom's DNA that she can pass on to a fetus in regular, non-exposed pregnancies that can change their susceptibility to different stressors later in life. So we know social determinants are involved. We know mental health of mom is also a very important epigenetic factor. We know that the relationship between cannabis and other substances is very complex and very hard to tease out. So how do we start to put all of that picture together to try to figure out what's actually happening and what the risk is and what the impact is so we can tell women and so that we can help care providers be able to feel comfortable with evidence-based information? However, as you learned this morning, there's some issues with the research. It's not that we haven't really tried, but it's really hard to study for all of the reasons I just gave you. You add on pregnancy, human pregnancy on there, it's easy to study the mice, but you add on human pregnancy and it becomes even more difficult. So it's really hard to control for maternal tobacco. We heard that today. Complex interactions we've talked about, social determinants of health we talked about, other prenatal and postnatal factors we've talked about, well, a little bit. THC levels in cannabis are not standard. We've talked about that today, other presenters. We know that there's lots of difficulties in self-report data, quantifying it, timing of exposure. We learned that the brain has different susceptibilities, but is always susceptible, but specific effects can happen depending on the timing of exposure. And that's always important to find out. And then there's the whole dose response question. So you can see how difficult this is. Can you imagine doing randomized controlled trials with pregnant women? Very difficult. And then animal models are great, but sometimes they don't always correspond physiologically, genetically. They don't really have some of the same complexities in terms of their environments, but the good news is we can control their environments. So we can very much control some of their prenatal experiences, and we can certainly learn from that to try to think about what questions we should ask when we're looking to find some answers related to women and humans. So there's a lot of million-dollar questions in this field. And you know, I just want to say we've been studying alcohol. We've known alcohol's been a neurobehavioral tragedy since 1973, and can we still tell people what's absolutely safe and what's absolutely harmful? No, we can't. So there's still those questions despite that long amount of research. So we have the same questions in the cannabis field. So I did a lot of digging to try to figure out what are some of those recommendations that are out there geared toward perinatal care providers. So what are some of the recommendations? And here we have some from the Americans. Clinically unimportant lower birth weights, no real differences in preterm births or congenital abnormalities. And then when you're doing guidelines, you always rank the recommendations on strength, right? And that's how robust is that literature? What's the probability of that literature changing with more studies? So how confident are we in that? And what does that say? Methodologic flaws. So not a really robust in terms of the science behind that recommendation. So what's the deal with, and this uses marijuana use and pregnancy have on the fetus and child, isn't associated with neurodevelopmental outcomes, may be associated with minimal neurodevelopmental kind of milestones that they have, isn't linked to increased substance use at age 14 years, but look at the strength of the recommendation again. Conflicting long-term prospective and retrospective cohort studies with methodologic flaws. So again, it's kind of like this is the best that we can do based on the literature that we have. So all that to say is this is very quick, I know, and a high-level overview, but what do we really know? We know that the effects still are unclear for lots of different reasons that we talked about, complexities and difficulties with doing really structured, delineating research. But we know there's potential. There's definitely potential, and the data in there are clear that there's potential, both from the human data, even though it's scarce, but also from the animal literature. Anything's possible. I also made up a quote. I was feeling very, I don't know, creative on an airplane. Anything is possible. Good science will bring the evidence. I'm a science geek. So what? So what does that mean? And so prenatal cannabis exposure may have selective deleterious consequences on executive function, higher cognitive abilities that could persist throughout the lifespan. Like alcohol, these effects may not be evident until later in life. They may be lifelong. We may be dealing with some invisibility because everybody could be born looking normal. It's not necessarily a craniofacial teratogen. We would have known that by now. And there could be structural and functional impacts in terms of fetal growth and development. So the SOGC, we get asked a lot about what do we tell, what's your position on this? What do we tell our patients? And so we also hear a lot that the healthcare providers that we work with are concerned from a pelvic pain point of view. They're concerned with breastfeeding. They're concerned with nausea and vomiting during pregnancy. They're concerned with anxiety and also folks that are already on medical marijuana. And what is that compromise? What is a compromise between risk of cannabis and then risk of not cannabis in terms of the other health-related issues that are being addressed? And so there's a lot of discussion in the field. For the last year and a half, we've had cannabis talks at our annual conference. And so there was a position statement put out that basically said the SOGC recommends women who are pregnant or contemplating pregnancy should abstain from cannabis use during pregnancy. Not must, but should abstain. And the recommendations always say, please talk to your care provider. So somebody asked me to talk about breastfeeding. What about breastfeeding? We know that there's transfer into milk. And we know that there have been, both in the human and animal models, decreased prolactin levels as well as potential maternal psychological changes. But the Americans have a statement on this, and they say, again, there's insufficient data. And the absence of data, they're discouraging use. Again, not a strong statement, but just saying there's not enough data out there. So we basically have a lot of work to do. So I got kind of intrigued. Again, you can get Wi-Fi on long flights now. It's fantastic. You can search up all kinds of things you would never think of in your normal workday. But I was interested. I studied preterm birth for a while, so I know that cortisol is involved with preterm birth. So I said, this seems to be the most robust potential outcome of cannabis use during pregnancy. So let me try to see what the relationship might be between cortisol and the regulation of preterm birth via cannabis. So I did a search, basic, cannabis, cortisol, pregnancy, and I have 0 search results. So I think that there's a lot of wide open space out there to start doing some research. That just makes sense to me. I don't know, I bet we could get a grant on that. And so that's sort of my really non-hyperactive overview of this. And so I think all that to say is, to sum everything up, is as a health professional organization who deals primarily with pregnant women, we're really relying on the science and evidence to be able to make those messages to our patients and to our care providers. And so we're working together with partners across the country, other health professional organizations, with Health Canada, with the Public Health Agency, to try to come together with some common messaging that's evidence-based, that providers feel good about, and that really tells a story, but also keeps in mind some of the other huge amount of confounding issues that have to be taken into consideration. So thank you. A long time.